Real life.
Hello, welcome all. Before we begin tonight's session on iFocus Online, I would like to make a very pleasant announcement that we will be holding the Physical National Postgraduate Education Program in Ophthalmology, the very famous iFocus, from the 9th to 16th of June this year in Hyderabad. So for that duration, we have from 10th to 15th of June at AIG Hospital Auditorium, all the lectures lined up for all of you viewing this to be present physically right there. We will have two sessions, hands-on 9th and 16th. We have the registrations limited to 300 candidates. And for the first 150, the hands-on session is going to be on the 9th of June. And for the next, that is 151st to the 300th registration, it's going to be on the 16th. Everybody of all those 300 candidates who would want to register can use the link below as shown on your screen, which is www.miraevents.com, and please use the QR code as well for registration. And we have Dr. Vijay Anand Reddy, sir, joining in for tonight's lecture. Before we, yes, we have him on board. Good evening, Dr. Vijay Anand, sir. Till Dr. Vijay Anand Reddy sir joins in, we have Dr. Ruju Unatkat showing us the A to Z of radiotherapy. So please watch in. And once Dr. Vijay Anand sir joins in, we will shift over to tonight's lecture. Stay tuned. Ruju, you can unmute yourself and share your screen.
A to Z of radiotherapy in ophthalmology. An ocular oncologist has to be a pantomath in terms of all the treatment modalities he or she has to offer. In cases where tumor is surgically inapproachable, or as a part of neoadjuvant or adjuvant treatment, chemotherapy and radiotherapy play a vital role. Radiotherapy specifically has revolutionized over the past few years with improved outcomes and better safety profiles. In this video, we will be covering A to Z of radiotherapy in field of ocular oncology, including basics of radiotherapy, various modalities of delivery, techniques of delivery, surgical procedure, indications, and related complications. Basics of radiotherapy. Radiotherapy is a therapeutic strategy that impacts the DNA and interferes with replicability of cancer cells by use of radiation in form of high-energy particles or waves. Electromagnetic radiation can be in form of X-rays or gamma rays. X-rays are generated by accelerated electrons, whereas gamma rays are emitted by radioactive isotopes. Particulate radiation includes electrons, protons, neutrons, alpha particles, negative pi mesons, heavy charged ions, and beta rays emitted by radioactive isotopes. Delivery modalities and techniques of delivery. Radiation can be delivered to the target tissue in two forms: teletherapy, when it is delivered from far, and brachytherapy, when delivered from a close contact with the target tissue. Teletherapy. External beam radiotherapy has evolved significantly over the period of time, starting from 2D EBRT, 3D conformal EBRT, IMRT, that is intensity modulated radiotherapy, where each field is subdivided into numerous beamlets whose intensities are individually modulated to achieve a non-uniform dose contribution from each field. In rapid arc modification of IMRT, with opening and closing of multi-leaf collimators, dose painting is achieved. Tomotherapy works on a principle of IMRT and delivers radiation by rotating around the body, aiming targeted beams at tumors from many angles. IGRT, that is image-guided radiotherapy, the workflow for which includes preparing a face mask. This is to manifest the superpower of our patients. Positioning with mask and infrared positioning. Verification with X-ray, CT scan or MRI for anatomical matching of tumor. Correction with 6 degrees robotic couch, snap verification at every couch angle, and finally the treatment delivery. Indications of EBRT includes lymphoma. In select cases of lymphoma, ultra-low dose boom radiotherapy has been used effectively. Adenoid cystic carcinoma of lacrimal gland, orbital retinoblastoma, orbital rhabdomyosarcoma, fibromyxoid sarcoma, solitary fibrous tumor, primitive neuroectodermal tumor of orbit, or Ewing's sarcoma family of tumors. Proton beam therapy is a newer advance which delivers higher lethal dose to the tumor with minimal damage to the surrounding healthy tissue. Stereotactic radiosurgery works on a principle of stereotactically guided conformal irradiation of a target in a single session using X-knife, cyberknife, gamma knife, or tomoknife for ultra-precision. Indications of stereotactic radiation includes surgically inaccessible tumors such as cavernous hemangioma located at or near orbital apex, optic nerve glioma, orbital apex meningioma, orbital apex schwannoma, choroidal metastasis. Brachytherapy. With brachytherapy, biggest advantage is that the required dose is directly prescribed to the apex of the tumor, minimizing the damage to the surrounding healthy tissue. There are basically two types: plaque brachytherapy, which has surface application, and interstitial brachytherapy. Indications of plaque brachytherapy include uveal melanoma, retinoblastoma, choroidal hemangioma, choroidal metastasis, ocular surface tumors with scleral involvement, like ocular surface squamous cell neoplasia, lymphoma, or melanoma. Sources for plaque brachytherapy includes iodine, ruthenium, cesium, iridium, and palladium. Iodine and ruthenium plaques have key differences when it comes to their half-life, manufacturing, and the requirements for protection and maintenance. Plaques can be of different shapes. Notch plaque is used for the tumors near optic nerve, and round plaque is used for surface tumors. Surgical procedure for plaque brachytherapy. As per quadrant and size of the tumor, the plaque position is decided. For posterior placement of plaque, conjunctival peritomy is performed. Recti muscles are hooked and tagged for the appropriate traction. The quadrant of plaque placement is exposed and scleral markings are done from the limbus, where ethibond suture with a spatulated needle is passed through partial thickness of sclera, avoiding any sort of scleral perforation. Suture is now passed through plaque islets and tied. Position of the plaque is confirmed and conjunctival sutures are taken. Plaque removal is done as per pre-decided dosimetry timings by the radiation oncologist. Interstitial brachytherapy surgery. In this procedure, after debulking or excising the tumor, hollow needles or tubes are inserted in a particular pattern and distance from each other into the residual tumor bed. Closure will be done with the tubes in situ. As per the radiation planning, at the time of delivery of radiation, radioactive source will travel through the hollow tube and deliver radiation to the tumor tissue. Radiation is delivered in multiple fractions, with each fraction at least 6 hours apart. The interstitial implant is removed after delivery of all fractions of radiation. Indications for interstitial brachytherapy includes residual and recurrent orbital tumors such as adenoid cystic carcinoma of lacrimal gland and rhabdomyosarcoma. Complications of radiotherapy and its management: loss of eyelashes, thinning of eyelids, periocular pigmentation which is reversible, dry eyes, the incidence of which can be reduced by reducing dose of radiation to lacrimal gland by IMRT technique, keratitis which is seen when higher dose of more than 50 to 60 gray is used and can be prevented by keeping cornea out of clinical target volume, cataract, radiation retinopathy, or rarely central retinal artery occlusion. A superlative evolution in the field of radiotherapy has enabled ocular oncologists to plan an implicit management protocol in a more structured manner, ultimately benefiting the patient in terms of improved rates of life salvage, eye salvage, and vision salvage.
Thank you so very much, Dr. Ruju, for that comprehensive video on radiotherapy. It really covered the A to Z. And then we now proceed with tonight's lecture by Dr. Vijay Anand Reddy, sir.
Share the screen automatically.
Yeah. Good evening, all. Back again on iFocus Online, episode 379, the 54th in the Oculoplasty module. Today, we have Dr. Vijay Anand Reddy from Apollo Cancer Hospital, Hyderabad, to speak to us on chemotherapy and radiotherapy in orbital disorders. Dr. Vijay Anand Reddy does not require any introduction. For him, is a towering personality in ocular oncology right across our country. He received his MBBS and MD from Osmania Medical College, Hyderabad, DNB in Radiation Oncology, National Board of Examinations, New Delhi. He is a consultant ocular oncologist at the LV Prasad Eye Institute and has been there since 1998. He is a director and senior consultant at the Apollo Cancer Hospital, Hyderabad. 2003, he founded the Cure Foundation. For us who work with him, know the importance of this foundation and many lives it has touched personally with. He is a member on the numerous prestigious committees and bodies, including the American Society for Clinical Oncology, American Society for Radiation Oncology, European Society of Medical Oncology, Union for International Cancer Control, and the Indian Society of Oncology, and many, many others. He received the International Fellowships in Clinical Oncology, Fellowship from the Meyerstein Institute of Clinical Oncology, London, the Nargis Dutt Memorial Cancer Foundation Fellowship of the New York Hospital, New York, Ocular Oncology Fellowship at the Wells Eye Hospital and Children's Hospital, Philadelphia, Head and Neck Oncology Fellowship at the Peter MacCallum Cancer Institute, Melbourne. And to his credit, he has won multiple awards for his outstanding work at national and international level. It's a pleasure to have Dr. Vijay Anand Reddy on this platform to deliver his lecture tonight. Over to you, sir.
Good evening, Prasad. Thanks for the kind introduction, and thank you, Raju, for before I could start anything that you could finish off the entire radiation. It was brief, but it was very nice. So it's a wonderful video that I heard that you got the best video presentation award for that video as well. All right. Anyway, so sharing my screen. This one. Yeah. So good evening, everyone. And honestly, today I completely forgot about this or missed out of my schedule. I was in Chennai the last morning, since morning 4 o'clock. I just landed and I drove directly to my residence, and Ruju was after me whether I'm reached this place or not. Finally, I could reach, and I requested Ruju to spend some time before I could get onto the laptop. So you can ask me any questions in between, and I'll be more than happy to do the answers in between as well, because I've not prepared for this lecture, but I've done it for several times. It's not a big deal for me to go through the slides. So let's talk something about management of ophthalmic tumors. Actually, majority of it is done by you guys. As far as the chemotherapy and radiation is concerned, I would like to brief what is that we can add on to what you do routinely in ocular oncology practice. So basically, we started the department way back in 2003. So I'll be changing the gears quite fast from benign to malignant tumors, briefly touching on each and every topic that we normally are associated with the ophthalmologist, ocular oncologist. So starting from the common problems that you encounter, one is about the hemangiomas. Hemangiomas can be choroidal or cavernous. If it is a cavernous hemangioma, we do external beam radiation, and the doses that are required to treat this hemangiomas do not cause any problems to the optic nerve. So it can be safely treated, and with the new technology, dose is confined exclusively to the hemangiomas, whatever the shape that it has. And we can also protect the lacrimal gland that you can see here. We can protect the lacrimal gland, globe, and lens as well. But if it is confined to the choroid, if it is a smaller one, less than 16 millimeters, we use plaque brachytherapy. But if it is a larger one, then we do external beam radiation. In whatever shape that you have, the entire posterior chamber, posterior part of the retina or 2/3 of the retina can be treated. Just behind the lens, entire choroid can be treated with external beam radiation. This is Graves' ophthalmopathy. I'm sure you have such cases coming to your clinic. Most of the time, Shashi, sorry, most of the times radiation forms as a later part of the treatment. Indications are only when you have proptosis, corneal exposure, and optic nerve compression. First line of treatment is always steroid therapy, and the patient comes back with a recurrence again and again. Then probably there are other, apart from the other modalities of treatment like surgical decompression, diuretics, and sometimes chemotherapeutic drugs. We also do external beam radiation. Especially if the patient is adult, it's easy to get away by doing external beam radiation because the dose delivered is less than 3000 centigrade without causing any problems to this patient. We can do external beam radiation, and it works very well. After a few attempts of steroid therapy, then you can look at if the patient has recurrences, then you go for external beam radiation. This is one of the patients with Graves' ophthalmopathy, pre and post treatment. Pseudotumors, there are several nomenclature for this kind of orbital inflammatory tumors, NSOIDs. We call them, earlier we used to call them as pseudotumors, now we call it as NSOID. It could be inflammatory, reactive, atypical lymphoid hyperplasia. Actually, there's spectrum starting from inflammatory to reactive lymphoid hyperplasia. It goes on to true lymphoma. So all these things properly has to be diagnosed, and it's very difficult for the pathologist also to clearly define the spectrum of lymphoid tissue. So whatever the terminology that you use, these tumors can be simply treated with external beam radiation, but we should make sure that there is no systemic disease associated with the tumor which is in the orbit. It could be regional lymph nodes, it could be distant lymph nodes, it could be hepatosplenomegaly, bone marrow involvement. When these things happen beyond the orbit, then you have to do systemic treatment. These tumors, if it is non-specific orbital inflammatory tumors, they require only low dose radiation confining to the target volume, and they respond dramatically to external beam radiation. This is before and after. Now coming to the malignant lesions, conjunctival carcinomas are quite often seen, and most of the times ophthalmologists, you yourself excise them. But normally when you excise and there is a base positivity, most often it is positive, and the margins, dissected margins cannot be wide. In such scenarios, we do plaque brachytherapy after post-excision. So they do really well, and without any morbidity, we can deliver high dose of radiation to the tune of 6000 centigrade. Sclera is a very resistant structure, so it's safe. It's very safe to deliver high dose of radiation of 6000 centigrade. To give plaque brachytherapy at the base where you resect in these patients. Some of the conjunctival carcinomas, if their tumor extends beyond the conjunctiva into the orbit, then we do external beam radiation. So we need to cover the orbital tissues as well if the tumor is going into the orbit. Now, eyelid basal cell carcinomas, squamous cell carcinomas, both surgery and radiation are equally good. What we need to look at about the morbidity. If you can excise it safely without causing much of a morbidity to the body, I would not, patient will have morbidity after doing excision. So in such scenarios, you can think of doing external beam radiation, and they do respond very well. Basal cell carcinomas or squamous cell carcinomas, they respond very well. Extensive lesions coming onto the skin, nasal area, going onto the upper eyelid. We have seen such cases, and those patients respond dramatically. to radiation treatment. See, such kind of tumors, it becomes very difficult for the excision. So we can do local excision and then post-operatively do external beam radiation as well. This squamous cell carcinoma, again, it's a Kiss ulcer, upper eyelid and lower eyelid both are involved, including the medial canthus. It's a squamous cell carcinoma, and post-treatment, you see the response. You're able to see this. Okay. Right, you see the response in post-external beam radiation, absolutely clear. It's not moving. Center, we're fortunate to have maximum experience in treating malignant gland carcinomas. And if you look at the data literature, they say 20% survival, 5-year survival is only 20%. I'm confidently can say, and we are so proud that we are able to deliver good excision with experienced surgeons, followed by external beam radiation. But these tumors are not as sensitive as basal cell or squamous cell. These are adenoid-cystic carcinomas most often, and adenocarcinoma. So these tumors require higher dose of radiation, that we should keep it in mind. So delivering a high dose of radiation in that tumor bed is mandatory. Then only you get results higher than what you see in the literature. So we have, I would say, almost 70 to 75% 5-year survival in our case series. So routine post-op radiation is mandatory because it's not possible to excise the tumor completely. Even if you excise tumor completely, the margins will be definitely positive. And the tumor, because it's an adenoid-cystic carcinoma, there is a high potential of tumor going along the nerves and vessels. So all these fissures, which we call it as escape routes, are very high chances that the tumor would spread from the lacrimal gland area to rest of the orbital tissues and beyond the orbital tissues through the fissures. So this is very, very important for an oncologist to target and include these areas in your target volume. So what are those areas? Superior orbital fissure, superior orbital notch, inferior orbital fissure, trigopalatine fossa, inferior orbital groove, inferior orbital foramen, and optic canal up to optic chasm. So all these areas need to be covered when you're treating the post-operative lacrimal gland carcinoma. So this is the phase 1, as I told you, all the fissures, including the temporal fascia, because the tumor is very close to external canthus and it comes out like that and gets into the temporal fascia. I hope you're all able to see the arrow which I'm showing.
Yes, sir. Yes, sir.
Right. So this area is very important and that need to be covered apart from the superior orbital fissure, optic canal, up to the optic chasm. So this entire area, excluding the globe, we go up to 46 to 50 gray. So the nerves, optic nerve can tolerate up to 50 gray, 46 to 50 gray. So we need to include we can actually include the optic nerve in the target volume. We only treat the tumor bed. So tumor bed is this area. You're able to see in a different color. So that area needs to deliver 6,000 to 6,600 centigrade. With the advance of technology, we can definitely treat up to 7,000 centigrade this area so that to get a better result. What will happen? Retina, which is close to that tumor bed, will definitely radiation retinopathy. But I think it's so the only part of the retina which is closer to the gland would get higher doses and patient would develop radiation retinopathy. So this is one of the, maybe the patient was treated almost 15, 16 years back and he completed his medication and he comes and says hellos to me in my office. So tumors which are huge and which are gone into the intracranial region. So intracranial extension tumors, these tumors do not do that well. In such instances, what we do, we do preoperative chemotherapy, at least 3 cycles, followed by surgery and followed by external beam radiation. We follow in Center for Sight and Prasad Hospital. So this is a standard protocol. Most of the medical oncology across the country and globe do not believe in chemotherapy, but our results show that we reasonably have good shrinkage of the tumor and makes the operability better, feasibility of surgery would be better. So ideally, you should give 3 cycles of chemotherapy, which also protects this, reduces the chance of metastasis at a later date. So it's better to give 3 cycles of chemotherapy followed by surgery and followed by external beam radiation. So sometimes we get patients from outside where the patients have already been operated and radiated, and most of the radiation doses delivered outside are hardly very substandard. So invariably they would come back with recurrence. In such situations, what we do, we see if we can, because the patient already received a 2000 centigrade is not going to have any impact on the tumor. So what we do is we excise the tumor and do a brachytherapy procedure. Brachytherapy is nothing but giving high dose of radiation to the tumor bed by means of active sources. So that will deliver very high dose in the tumor bed. So that is an advantage, especially when you have a recurrent tumor where we can't give external beam radiation. Additional external beam radiation will not be sufficient. We do this treatment. So excise the tumor, and in the tumor spots here. So with 1 centimeter gap, we do these tubes placed in the tumor bed, and then the patient will be shifted to the after loading area. The machine has got the sources, and these sources are pumped into the area where the tubes have been placed. That will deliver very high dose of radiation to the tumor bed. That's the greatest advantage of this interstitial brachy. These tumors, most often we do it in have patients already been treated elsewhere and their parents. Another lady from Kolkata, radiation post-interstitial brachytherapy. Malignant gland carcinomas, highly malignant tumors. If you don't treat properly, a third of the patients will lose them. So most often it is multicentric and very high chance of local recurrence. So surgery followed by post-op radiation is mandatory. And radiation, again, doses have to be 6,000 to 6,000 centigrade, 6,600 centigrade. And we should remember that the regional lymph nodes, that means the preauricular lymph nodes and the jugular-digastric lymph nodes also has to be treated along with the primary target volume. That is where the primary tumor presentation, or the patient already has lymph nodes in the time of presentation. What we do again, we take the help of chemotherapy. Again, 3 cycles of chemotherapy. Then most of the patients respond dramatically. This patient, this massive tumor with preoperative lymph nodes. See, the lymph node, pre-chemotherapy, preauricular lymph node and the primary tumor have regressed significantly with just 2 cycles. So we continue with another 3rd cycle and 4th cycle of chemotherapy, then excise it, and then do external beam radiation. So she's completely disease-free even after 6 years. What are the drugs that we use? The commonest is cisplatin and 5-fluorouracil. If you look at from the first protocol, which is day 1 to day 5, it's quite cumbersome. So it's easier to do with paclitaxel on day 1 and ask the patient to come back on after 21 days. So either of these protocols is acceptable. What we follow is cisplatin and paclitaxel. And if the patient cannot afford, then you can go for cisplatin and 5-FU. Orbital lymphomas, as I told you in the past, atypical lymphoid proliferation goes on to lymphoma, non-Hodgkin's lymphoma, low-grade or high-grade non-Hodgkin's lymphoma. We have to differentiate because it's very important. If it is a high-grade lymphoma, systemic chemotherapy becomes mandatory. If it is a low-grade lymphoma, marginal zone low-grade lymphoma, extranodal marginal zone low-grade lymphomas, or lymphoid hyperplasia, or atypical lymphoid hyperplasia, All those things can be treated locally by external beam radiation. Nevertheless, you should always make sure that there is no systemic disease in the same patient by doing the routine workup. Very important. If most of these are low-grade orbital lymphomas and they do not have systemic involvement, only 10 to 15% of them can develop systemic disease at a later date. And the results are quite gratifying in a isolated low-grade orbital lymphomas. This is a patient before treatment and after treatment, a complete regression of the lesions. The target volume of the lymphomas, if it is a marginal zone NHL, localized field of radiation is more than sufficient. But if it is a low-grade follicular NHL, then it's better to include the orbit. You all know it's a loose structure, loose tissues all around, intraconal and extraconal areas. So in those situations, it's better to treat the entire orbit. And that is not going to cause any kind of morbidity because the dose delivered is much lower than the toxicity that can happen to the optic nerve or retina. So if it is a high-grade lymphoma, as I told you, it's better that we involve chemotherapy first and then consolidate with external beam radiation into the orbit. Now, rhabdomyosarcoma, head and neck rhabdomyosarcomas are the most common, and out of which orbital rhabdomyosarcoma, even most common site in head and neck malignant, head and neck RMS. And lymph node distant metastasis involvement, unfortunately, are rare. 90% disease-free survival. We have very gratifying results if you treat these patients in a proper protocol way. The commonest what we see, there are various types of RMS, and of which embryonal is the most common, and fortunately, that is the best prognosis that we can achieve if the tumor is embryonal. Next in line is pleomorphic, also is good prognosis. Alveolar, undifferentiated anaplastic, have got poor prognosis. By the time we start the treatment, the chances of metastasis, chance of relapses are quite common in alveolar and undifferentiated anaplastic tumors. These tumors respond very well, but recurrence chances are very high in other types, which are alveolar, undifferentiated, anaplastic. But fortunately, most of them are embryonal and pleomorphic, and 90% to 95% of them, they do really well with chemoradiation. So if it is an isolated small lesion, complete excision, no need to do any further treatment. But if there is a microscopic disease, most often this is a scenario where you have microscopic disease as well. You excise it and followed by you plan to give adjuvant chemotherapy. But the commonest scenario what we see is an orbital RMS protrusion, massive tumors, retinal extensions. So that kind of tumors are all we need to start with just to get a biopsy done, make sure what kind of tumor the patient has, what type of RMS the patient has, do a systemic workup and start with the chemotherapy. It's always is a standard international protocol. COG protocol is VAC alternating with E. That means cycle A and cycle B to 3 cycles. That means 6 doses. Subsequent to that, you have to consolidate with local radiation. And subsequent to that, again, go back to the chemotherapy, which is going to be 6 doses. So totally 12 doses of chemotherapy and sandwiched with radiation in between. Stage 4, it's palliative. It responds very well, but the chance of a complete remission are rare, or less than 20%. So briefly, surgery followed by excision and excisional biopsy is ideal if it is a small lesion. Complete excision, no treatment. Incomplete excision, adjuvant chemotherapy. But if the incomplete excision is gross residual disease, then you have to look at radiation as well. Most often we have patients presenting to us are locally advanced. So as I told you, multi-drug chemotherapy, VAC alternating with IE, followed by radiation, followed by subsequent chemotherapy. So these tumors have gratifying results. Even the massive tumors, a patient presenting with massive tumors, don't hesitate to treat them with a radical intent, and they are highly curable. Pre-chemo and post-chemo, and the clinical target volume is again, all the escape routes have to be included because the tumor spreads through these areas. So we need to include the entire orbit, include all the fissures in the larger doses, larger volume with 45 to 50 gray, but confined to the original target area. If the tumor is confined to one area, you can escalate the dose from 45 to 54 gray boost. This is a patient 4 years later. That's a massive tumor, and post-treatment, absolutely normal. With the recurrent RMS, improperly treated, inadequately treated patients would have massive recurrences, but don't get disheartened. You can still salvage them with a proper chemotherapy. This patient has received 2-drug combination for 28 cycles. So that's the way these patients do come back with recurrence. So we salvage this patient with chemotherapy, and this child is really doing well even today after 4.5 years. Such a massive tumor, salvage chemotherapy, responded very well. Subsequent to that, external beam radiation, and is doing well. PNET tumors, they are quite destructive, as you might have seen. Surrounding bones are all destroyed, and most of these tumors respond dramatically to chemotherapy. But you should understand that these patients require close follow-up. A very high chance of recurrences in these patients. So, but our job is to treat these patients with radical intent, and we do get gratifying results, and several of our patients are still doing very well without any recurrence or metastasis. We do a standard international protocol VAC with IE. Here the VAC is anthracyclines, whereas an RMS A means actinomycin D. Here we use anthracyclines, which is adriamycin. So VAC alternating with IEs, similarly, we do 6 cycles of chemotherapy, local radiation. But here the radiation is not done after 6 doses of chemotherapy. We initiate the treatment after only 9 weeks. That means 2 cycles of chemotherapy. Then we start with radiation, and then complete the next 10 cycles of chemotherapy after completion of radiation. This is one of our patients. See the destructive lesion, destroying all the bones around, and the patient post-chemotherapy. Look at the dramatic response and reorganization of the bone as well. At diagnosis completion, 2 years, 4 years. Now she is almost 9 years later, she still comes for the follow-up. Retinoblastoma, yeah, briefly on that. Our role is only when the tumor is group C and group D. Group A and group B, you take care with the local therapy. But in group C and group D, the tumor is bigger in size, where not amicable for local therapy, then we do chemo reduction. Chemo reduction is nothing but by doing chemotherapy, the tumor reduces in size. Subsequent to that, you can do local therapy. In some situations, we do plaque brachytherapy. The tumor is resistant to chemo reduction and local therapy, and the tumor size is less than 16 millimeters. Then we do plaque brachytherapy. Some tumors which are big and tumors which have vitreous seeds not responding to chemotherapy, then external beam radiation. All in all, the radiation in retinoblastomas has taken definitely a back seat, because chemo is working really well, and the expected morbidity with external beam radiation is not acceptable, because most of these are children who are less than 4 years. So long-term morbidity with radiation is a high possibility. For that reason, although it is very sensitive to radiation, we prefer to use chemotherapy. And other areas where radiation is chemotherapy is involved is group E, where after enucleation and as an adjuvant treatment, based on the high-risk features, we do adjuvant chemotherapy. If the tumor is out of the sclera, extrascleral extension or cut end of the optic nerve is positive, then we do external beam radiation. So chemo reduction is nothing but reducing the tumor volume and allowing you to do local therapy, that making your job easier. Plaque brachytherapy, as I told you, we use it very less often, only when it is required, even after delivering local therapy and chemo reduction. If the patient has recurrences, then we do plaque brachytherapy. Plaque brachytherapy, in a chemoreduction failure or recurrence, rarely as a primary modality of treatment. What we use is ruthenium. We can also use iodine 125. And this is one of the first patient which was done 18 years back, and child is still doing well with plaque brachytherapy way back in 2002. External beam radiation indications retinoblastoma only in a persistent RB. Very rarely we use radiation. And recurrent group B, and when a patient has diffuse vitreous, especially bilateral retinoblastoma, and the patient patient attendants do not want to go for enucleation, then we take these measures of doing external beam radiation. And obviously post-excision, post-enucleation, and orbital RB, after neoadjuvant chemotherapy, after adjuvant chemotherapy, external beam radiation becomes mandatory. So what are the indications of radiation, external beam radiation? Optic nerve invasion at the level of transection, scleral and extrascleral extension, inadvertent ocular perforation. By any chance somebody does biopsy, somebody misdiagnosed retinoblastoma and put a needle there, then it becomes ocular perforation. So in those situations also, after the standard treatment, you do external beam radiation. Intraocular surgery in unsuspected retinoblastoma also. That means there already a spillage, so we have to do external beam radiation. That becomes an orbital retinoblastoma, obviously. So in all orbital retinoblastomas, you have to do external beam radiation. Does adjuvant therapy help? So our data analyzed definitely gives an indication that by giving adjuvant chemotherapy, metastasis would be reduced to almost negligible, and local recurrence chances also get reduced. Orbital retinoblastoma, earlier mode of treatment was first orbital exentration, followed by external beam radiation. But now we reverse the protocol, start with systemic chemotherapy, and then do enucleation or exentration, followed by external beam radiation, and continue another 6 cycles of chemotherapy. So then from 70% mortality, we have improved the survival by 70%. So neoadjuvant chemotherapy, see the dramatic responses with chemotherapy, following which we do surgery, and then following surgery, we do external beam radiation and continue and complete the full course of chemotherapy. Plaque brachytherapy, high doses can be delivered without causing morbidity to the surrounding structures, and precisely and selectively only to the bed where you are delivering the brachytherapy. And minimal dose, obviously, very, very minimal dose to the surrounding structures, because dose fall is within few millimeters, dose is already completely negligible. And we can selectively dose distribution can be done, and that thus it reduces the complications of external beam radiation. Plaque brachytherapy indications, it could be a melanoma, retinoblastoma, hemangioma, metastasis, hemangioma of the retina, or ocular surface tumors, which are OSSNs. Commonly used are iodine and ruthenium. Ruthenium has got an advantage for the simple reason that it has got different shapes with the, for the cornea, you have a nice cut here, and for the optic nerve, you have another cut here. So it's very usable and friendly, and the best part is the half-life is almost 1 year. So that's the greatest advantage of ruthenium plaque brachytherapy. So you look at the dose fall, you are giving 5,000 here. Within few millimeters, it is only 500 centigrade. So that's the greatest advantage of plaque brachytherapy. So the results in retinoblastoma, the pre-plaque brachytherapy and post-plaque brachytherapy. Now, for hemangiomas, again, time to respond, it takes 6 weeks, it responds very well. Impression, so 90% responses are seen in hemangiomas. They become flat in reduction in height, and the subretinal fluid also completely reduces. Choroidal melanomas take time. Time to respond is 6 months. 80% of them would respond. Flat, less vascular, and they become color becomes brownish, and the subretinal fluid also reduces. Ocular surface tumor, you excise it and then put the plaque brachytherapy there. That's the best way to go about. And most often the bases are positive. It's better to deliver 6,000 centigrade to those areas. Doses vary based on the histopathological diagnosis. Hemangiomas lesser doses. OSSN would have a standard squamous cell carcinoma doses of 5,000 to 6,000 centigrade. Regression, hemangiomas, almost 100% of them would respond. OSSN 82%, retinoblastoma around 2/3 of them would respond because that is used as a salvage, not as a primary modality of treatment. Uveal melanomas, 92% of them would respond. Proton wave, briefly on the proton wave. Today I've been to Chennai to deliver proton beam therapy for a couple of patients. So it's a fascinating technology. The advantage of that is that the photons enter and exit. We can't stop them, but only the dose delivered will be higher where we want to deliver, and rest of the areas would get 30 to 40%. Whereas the proton, you look at the green here, protons, we can stop the radiation abruptly wherever you want to stop. So that is the greatest advantage of proton. That's the reason why, choroidal melanomas, we can deliver treatment with protons. We can deliver higher dose of radiation compared to photons because there won't be any spillage of radiation to the neighboring areas. So that's the greatest advantage of proton. So commonly used in ocular melanomas, pediatric tumors, head and neck malignancies, breast, lung, prostate. Some of the, if the time permits, I'll just briefly, very rare tumors in ophthalmology. Time is there, or shall I stop it?
So you may
please go ahead. Please continue.
All right. So orbital apex meningiomas, optic nerve gliomas, optic nerve schwannomas, all those things can be safely treated with the new technology that is available these days. So you look at the dose volume histogram. This is to tell you the normal structures are getting very, very less dose when you are targeting the tumor to 100%. The optic nerve 10%, 8.5% to the cornea. That is the greatest advantage of this new technology, what you call it as stereotactic radiation, which Vijay has shown in our video. So any small lesion at the apex of the tumor, this is an orbital apex schwannoma, we should be very, very careful in treating because optic nerve gets full doses. So these tumors can be safely treated with experience and expertise and the gadgets that we have these days. We can deliver safely and we can control these tumors. This is one of the patient at the age of 18 years we treated. Now 4 years down the lane, our vision is absolutely normal. So orbital apex schwannoma, this is a dose volume histogram. Other structures getting very less dose, the tumor is getting 100%. Optic nerve gliomas, as I said, so these tumors also can be safely treated these days with very good dose volume histogram, protecting the normal structures. Solitary plasmacytoma of the right orbit is another very rare cases. Treated patient at 72 years, male patient presented with isolated plasmacytoma without chemotherapy. We did only local radiation with gratifying results. Plasmacytoma DVH. This is very interesting. The choroidal metastasis, when you have the tumor which is bigger in size, bigger than the plaque capacity, then we can do external beam radiation with stereotactic. Breast carcinomas, lung carcinomas, choroidal mets. We do just 2 to 3 doses of radiation and the patient will have normal vision. See the tumor, if you look at the previous slide, this was a tumor, the big lesion, and post-treatment, complete disappearance. And this same patient after 2 years developed metastasis in the opposite eye, the choroid, entire choroid is again being treated. So bilateral choroidal metastasis can be safely treated with this technology. Lymphoma of the conjunctiva, external beam radiation is the safest, pre and post treatment. Fibromyxoid sarcoma, low grade 1, it was very difficult because the tumor was going intracranially. So we did neoadjuvant chemotherapy and then external beam radiation. So no surgery, orbit is intact, eye is intact, no vision though, but the child is active and is doing really well even today. He is very, very playful, and this is 36 months picture, but I've seen him after 6 years as well. Radiation-induced complications, Riju has already shown. Eyelashes are spared. The new technology, eyelashes are not lost. Even sparing, minimal loss might be seen, but they come back without any problem. And eyelids can become thinner, but the function will not be altered. Cornea has to be protected. As a radiation oncologist, we have to be very, very careful in looking at the dose to the cornea, dose to the optic nerve. So all those critical structures, each structure, it is very well defined how much dose that it can tolerate. So we should be careful in planning and executing the treatment in all these areas: retina, optic nerve, cornea. Lens is not an issue because even 200 centigrade will cause cataract. So we don't bother about it because we can do excision of excise the lens can be replaced. Lacrimal glands can be spared when you're treating other than the lacrimal gland carcinomas safely, and the dryness is reduced these days. So we need to balance between the benefits and morbidity at the same time. Make sure that you get a cure without affecting the quality of life of the patient. We need to have certain attitude to do that, and we should not be scared in treating these eye tumors. Unfortunately, most of the centers, they get recurrences in these patients. So it's very important that ophthalmologist and oncologist coordination is very, very important. At what time, what need to be done, the sequence of events, whether chemotherapy should be done first or chemotherapy should be done later, radiation should be done first or radiation should be done later. So what is the sequence that you should follow in that particular patient? That need to be discussed before you execute the plan of treatment. So that makes huge sense, following a proper protocol, after proper discussion in a multidisciplinary meeting, then it works out well. So attitude is very, very important. So they don't give up on a patient who had recurrence, don't give up on a patient who has got massive disease. So these tumors, most of them are sensitive to chemotherapy and radiotherapy, and they dramatically respond with 1 or 2 cycles of chemotherapy. It can convert that ugly, bad-looking tumor, nasty tumors into curable disease, and we can treat them and cure them. We should have a positive attitude, and you should take the patient into confidence, patient attendants into confidence, and make them understand that they should follow the entire protocol properly. Then only they get these good results. Thank you very, very much. If you have any questions, I'll be happy to take it.
Thank you so much, sir, for the wonderful presentation. I know you have been not keeping well, and you were also traveling, and you had such busy schedule. But you agreed to deliver this talk, and I think it will help many, many postgraduate students and many fellows like us. So thank you so much, sir, for that. And if you allow, I would like to take few questions.
Sure.
Yes, sir. So the first question we have received is incidence of hematological malignancies post RB chemo in your practice, sir.
We have in the literature used that the malignancies, we don't have follow, but briefly I have seen only 2 patients coming back with hematological malignancy. Especially in retinoblastoma, these are more prone to develop solid malignancies than hematological malignancies. Solid malignancies, I have seen osteosarcoma, fibrosarcoma, post-radiation. But post-chemotherapy, although we know that etoposide is carcinogenic and we do 12 to 24 cycles of VEC chemotherapy, we haven't come across any patients with leukemias in recent. Although we have 25 leukemias. You should also understand that the latent period for developing hematological malignancies is shorter. So if they have to develop malignancies, that should happen within 5 to 6 years. Whereas solid malignancies, the latent period is almost 10 to 15 to 20 years. So we have seen children, adults and children coming back with fibrosarcoma and osteosarcomas. Next.
Sir, role of neuroprotection while delivering EBRT in case of orbital tumors, and how do we actually give it?
Neuroprotection, you mean to say optic nerve, optic
Yes,
chiasm.
sir.
These are the two structures, that optic nerve head from there. We look at optic nerve. Fortunately, we look at the mean dose. Total optic nerve is in the radiation field. A certain amount of dose can be delivered. If only part of the nerve is in the radiation field, higher doses can be delivered. And it's only point dose. We call it as a median dose, total nerve dose, and the point dose. If only part, a few millimeters or less than 1 centimeter part of the optic nerve is in the radiation field, we can go up to 6,000 centigrade. So we have our data, international data, what is the risk of this optic nerve and optic chiasm to a certain dose. So that is what we keep in mind whenever we deliver the radiation to these patients.
And sir, is there any role of oral steroids and multivitamins along the radiation?
Absolutely true. So whenever your entire optic nerve is in the radiation field, or optic disc also has to be included in the radiation field, we take the help of steroids. We do steroid along during the period of radiation and 2 weeks subsequently, and then taper it off.
Sir, can you please explain in brief about low dose radiation, boom radiation in cases of lymphoma?
Yeah, it's a fancy word, boom radiation. So it's applicable only in a atypical lymphoid hyperplasia or a very low grade non-Hodgkin's lymphoma. So where there's a tumor is very small, not infiltrating the orbital tissues, then you can, there is a data supporting this boom radiation, which is just 200 centigrade in a single fraction, or 400 centigrade in two fractions. So they even tried 500 centigrade in one fraction. But the data says that these patients had recurrences at a later period. So the recurrences are more common if you do this boom radiation. That means slow, so a small dose of radiation in 1 or 2 fractions. When you do full dose of radiation, the recurrences will never happen. 95 to 99% recurrences will not happen. So they can consider boom radiation in an elderly patient who is around 70, 80, and you don't bother even if you have a recurrence. So, and also that's very difficult for them to come every day for 2 to 3 weeks. So you can think of doing that kind of low dose radiation. So it's nothing but one single dose of 200 centigrade to 400 centigrade.
So the next question we have is, how do we decide for the extent of radiation to be delivered in a case of lacrimal gland mass post-excision?
So we need to target the pre-operative volumes. So CT scan and MRI scan, which was done prior to surgery, that is our goal, not the post-operative. Post-operative residual disease is a second phase 3. So the primary target volume should certainly be engulfing the entire primary tumor which was there prior to surgery. So that is very important. And the microscopic extensions, which I already told you, escape routes, the entire orbit and all the fissures, including the temporal fascia, has to be included to a certain dose, which is 45 to 50 gray. Then you come to 6,000 centigrade to the primary target, which preoperative areas, which those need to be targeted to 6,000 centigrade. And then further 600 centigrade is delivered to the suspected residual disease post-operative. How much ever is the residue, post-op changes, you call, somebody call it as, so post-op changes, somebody says there is some diffusion restricted area. So we suspect that area, so we get deliver 6,600 centigrade to 7,000 centigrade. So that's the way you phase out the radiation doses.
And the sir, last question we have for the day is, sir, when do we start adjuvant radiation in case of extended orbital tumors post-orbital excision?
After completion of chemotherapy. So either you complete 6 cycles of chemotherapy, the standard is 12 cycles, that you should remember. All these orbital retinoblastomas, you have to go for 12 doses of high dose chemotherapy. High dose is nothing but the etoposide dose will be double, P-Christian will be same, and carboplatin dose will also be doubled. So 6 cycles of chemotherapy is mandatory, followed by external beam radiation, and continue another 6 cycles of high dose chemotherapy. So in case the patient has some logistics issues that they cannot stay for 1 month after 6 cycles, you can extend it to 7 cycles, 8 cycles. But you can ideally should be sandwiched because it's an orbital tissues. Local radiation, if you do it early, is better.
Thank you so much, sir. That's all questions we had for the day.
Hi, sir. Mritika here.
Hi, who is this?
Mritika.
Hi, Nitika, long time.
Yes, sir. How are
I'm
you?
able to see you now.
Sir, I had a question, if it's okay to ask.
You can ask, but you are a senior consultant. You should not have any questions. You learned a lot.
No.
Go
Sir,
ahead.
I just wanted to ask you that in India currently, what are the targeted therapies that we are using and for which related to ocular oncology or ophthalmic tumors? What are the targeted therapy that we are using and for which tumors?
See, targeted therapies can be multifocal. So what are the targets that you have in various tumors or what we see? Some unusual targets in adenoid cystic carcinoma have HER2 positivity, which is most commonly seen in the breast. So we use trastuzumab, right? Rituximab, which is commonly used in all lymphomas. And immunotherapy is another area where we look at if you have a high tumor burden, tumor mutation burden, or if the MSI is unstable. Those kind of tumors, or PD-L1, and sometimes we check PD-L1. In these things, then if any of these things are positive, then we can use immunotherapy. Immunotherapy is more often is used in melanomas rather than any other squamous cell carcinomas also of late we have certain targets. Epithelial growth factors, receptors are always there in these tumors. So we can try multiple tyrosine kinase inhibitors or MAPs, cetuximab, nimetuzumab, in epithelial-based tumors, squamous cell carcinomas. But these tumors are used only in a metastatic. These target therapies are used in a metastatic setting, not as an adjuvant setting.
Okay.
So as of now, we use adjuvant setting only for melanomas. High-risk melanomas, we do immunotherapy. Even that data is not robust. So we look at very few areas, then we can do adjuvant. When you have a very high potential of metastatic disease in a melanoma, then the role of immunotherapy comes as an adjuvant. Otherwise, most often they are used in a metastatic setting.
So in a non-metastatic setup for uveal melanoma, which are the adjuvant therapies that we are using? And like, if it's not extraocular and we don't have genetic data for it, then how do you decide when do we give adjuvant?
Post-excision in a choroidal melanoma, we don't advise adjuvant treatment. Just have to keep them on a follow-up. So we have targets, we do molecular analysis and V6, V600, BRAF mutations, and PD-L1. Adjuvant treatment, I don't suggest as of now any adjuvant treatment for these melanomas. So local treatment is definitely required in the form of external beam radiation. So besides that, prevention of metastatic disease in a choroidal melanoma or uveal melanoma, although the potential of metastasis are there, as of now, adjuvant immunotherapy is not a standard of care.
Okay, sir.
So let's have a one-to-one discussion later. Let others also ask some questions. You are free to call me anytime, Ritika.
Thank you, sir.
Dr. Mritika, in fact, that is a very interesting topic, targeted therapy in field of ophthalmology, and your wish, our command, and to speak to about targeted therapy in ophthalmology, we have Professor Hakan Demirci speaking to us on the same topic on in our next session, that is on 16th
I thought
of
you'll be
February.
asking me to speak on the topic. That's my favorite topic. Anyway, let me know who is talking on it. I'll log in and listen to him.
Dr. Demirci is there. In fact, that is why I wanted your opinion, sir, because he'll be giving us a more global view, but you have the, what is applicable in India and what's happening.
I'll see if I can join that day. So then we
That's
can
on
have
Friday.
interact. Yeah, we can interact. All right.
Yes, sir. All right, sir. Happy Valentine's Day.
Oh, so sweet. You spoiled my Valentine's Day, and again you're saying
I know. I'm so sorry. That's why I'm wishing